Good evening, sir. Am I audible?
Yeah, good evening. You're audible.
Good evening, sir.
Yeah. Your name is Agnik, no?
Yes, sir. Yes, sir. Yes,
Yeah,
sir.
great, good. So myself, Dr. Rajendra from Chennai.
Yes, sir. I think we have met before. We have done sessions before.
Yeah, yeah, yeah.
Dr. Verghese Thomas would also join probably.
Yeah,
Dr. Verghese Thomas and Professor Jayanti ma'am. Like
yeah, yeah.
ISG Kerala is to like always it's a constant at Clarinet. So it's okay. Uh,
Okay.
Today Dr. Pawan sir would present it, right?
Yeah, yeah.
Yeah.
Uh,
And
and
I have some doubt.
yes, sir.
Are you providing free this clarinet to ISC Kerala?
Free, sorry, sir.
This sessions and all you are providing free, yeah?
Yes, sir. This
Mainly?
is the yes, sir. The sessions are free.
Okay. So actually, from Tamil Nadu side, I am doing the classes. So
Oh, okay,
through
okay.
my personal mail only.
Yes,
Can
sir.
you help in this regard?
Yes, sir. The thing is, the institutional relations team that we have,
Okay.
uh, I'll just tell them the query that I'll just let them know that you have
Okay.
this request, so
Okay.
they'll get back with you because they create the dates, association times, and sessions. We are
Yeah.
the moderators. We provide technical support. We
Okay.
moderate the session, but
Yeah.
like scheduling the session, it's their part. So I'll let them know this
Okay.
request, and they'll
Okay.
get back to you for
Okay.
sure.
Can you note my number?
Yes, sir. Sure, sir. After the session, you
Okay.
can give me it in the chat box,
Okay.
or like you can give it right now also. No issues. I'll
Yes.
just let them know
Okay.
that you have this request.
Sure. Sure.
Okay, sir. And one of them from the institutional relations team would call you.
Okay. Okay.
Okay, sir. Also, sir, today also after giving the intro, I'll hand it over to Dr. Verghese Thomas, sir.
Okay. Yeah.
Okay. Okay, sir.
Sure.
And sir, does anybody have any slides to present?
Yeah. Dr. Pawan only.
Yeah.
Dr. Pavan is the presenter.
I will be presenting the slides.
Yes, sir.
Okay.
Can you just like share your screen once before the session so that we can
One
have a
minute.
trial run kind of a thing so that during the session it goes smoothly. Yes, sir. Just make it in a slideshow mode.
Yeah.
Yes, sir. Go
This
through
is
the
okay.
slides. Yes, sir. Just go through the slides once. Yeah, sure. Okay. No issues. No issues. Okay, sir. No issues. We'll wait for the other faculty members to join in. Then we can start at the designated time.
Can I keep the screen like this only?
Actually, sir, you can keep it, but while I give the intro of Clarinet, I'll have to share a video of Clarinet as well. So during that time, I need to stop the screen sharing of the other participant.
Yeah.
After that,
Okay. 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 So
when they
stop
call
share.
you up,
Hello.
yes, you can stop sharing.
Yeah. So I will.
When the
Yeah. This is okay.
association would call you up, then you can share the screen, and then you can move on
Yeah.
with your presentation.
Okay. Okay. Okay.
Good evening, everyone. We have 5 minutes to go. Can I just ask who would be the moderator from the association side today? Dr. Verghese Thomas, I also not sure. Good evening to one and all present here. This is Shagnik, the designated moderator from ClearNet for this session. ClearNet is very proud to be a part of this digital partner. Now, I would like to play a short video of ClearNet before we move forward, which would give its introduction. Thank you all for your kind patience. As we all know, ClearNet is India's largest live digital CME and doctors generated medical content platform, which is exclusively free for all the medical practitioners. You all are requested to visit our website www.clearnet.com, where you can watch lots of live sessions conducted by doctors with great expertise all across the globe. We also have MedWiki service, which is a medical Wikipedia, which is exclusive for the doctors to read as well. We are very grateful to this association and this star-studded panel with such highly affiliated doctors to be associated with us. Now, before we start the session, I would like to go through a few things. I would like to kindly remind you that whenever a doctor or a participant is giving a presentation or has the virtual stage, I would like the other participants to keep themselves muted for smoother audio streaming. Also, while any faculty member is taking up this virtual stage to speak, I would like them to keep their video on as well. Now, without further ado, I would like to hand over this session to Dr. Verghese Thomas, sir. Sir, if you may please take the virtual spotlight and continue with the session.
Thank you, Mr. Sagnik, for your kind introduction, and hope you will be staying with us till the end of the program. And I request to make Professor Ganesh Pai the co-host, so that in case if you want to point out on the slides, it will be easy. Okay, so please make Dr. Ganesh Pai the co-host of the program. Okay, and welcome to today's class by Isgk. We have a very eminent and senior and renowned faculty today. Professor Ganesh Pai, Professor of Gastroenterology of Kasturba Medical College, Manipal. And is a very senior person, very academic person, lot of publication, very sought after examiner, and a great teacher. So we are actually really fortunate to have him with us today. And you, all the students, you'll be, I am sure you'll be enjoying a very good class by Professor Ganesh Pai. So a warm welcome to Professor Ganesh Pai. Okay, now today's class is presented by Dr. Pawan of Medical Trust Hospital, Kochi. And the discussants are Doctors Sadguna Rao from Apollo and Dr. Shumuk from Trippuram, Chennai. So the pattern will be that Dr. Pawan will be presenting the initial aspect. At any point of his presentation, the faculty can intervene and ask questions, clarify, just like any teaching clinics at any time. And at the end, Dr. Pawan will summarize his history and of syndromic diagnosis, differential diagnosis. Then we invite other two participants also give their opinion. And after that, we will discuss
I would ask everybody to be with us. Sir's net got disconnected. Sir has connected again. Yes, sir is back. Sir, you're on mute, sir. I've sent you an unmute. Yes, sir.
Okay. So after that, they will discuss the line of investigation. Once the line of investigation is discussed, we will show the available investigation and discuss. The third discussant will be mainly discussing the management aspect. Now, Dr. Kadam, upload your slides, and I request Professor Ganesh Pai to take over between, because they are at the moment busy and they have not reached format. Okay, over to Professor Ganesh Pai.
Thank you, Dr. Varghese. Those were very kind words. I think without much ado, if our candidates are ready, we should go ahead with the presentation. Are you ready?
Pawan, are you ready? You can start off.
Yes, sir. Yes, sir. Am I audible, sir?
Yeah.
You are. Yeah.
So, good evening, respected professors and my colleagues. Today case is one 74 years old gentleman who is a retired state transport bus driver, currently working in his farm. Is a resident of Kannur district, Ernakulam. He is educated up to 4th standard. The history is given by the patient himself and it is reliable. Uh, so he presented with the complaints of loss of weight, fatigue, loss of appetite since last 3 months, yes, early satiety, abdominal pain, recurrent episodes of vomiting since last 2 months, and feeling lump in abdomen since last 1 month. So, history of present illness. Patient was apparently all right 3 months back when he started experiencing the loss of appetite in the way that he initially, he previously was able to take two appam or big bowl of rice at a time, which gradually decreased up to now he can barely eat 2 idlis, which gradually got worsened with early satiety, so that he feels abdominal fullness even after taking a glass of water. Patient also experienced gradual loss of weight since last 3 months, which he observed by loosening of his clothes. Patient also abdominal pain, which was mild to moderate in intensity. Which was dull aching nature with no radiation. Uh, his pain, particularly, he says, used to aggravate with intake of after few minutes of the intake of food, and the pain used to improve with episode of vomiting. The vomiting episodes were associated with nausea, and they were non-projectile and no evidence of any blood in vomitus, and those vomitus contained the food he has ingested recently. So another major complaint, patient also started lump in the upper abdomen, which he first noticed 1 month back, which he initially described was the size of lemon, which gradually progressed up to the size of orange as he describes, and lump did not used to regress after vomiting episodes. So there was no history of any severe abdominal pain requiring IV medication before the presentation of the patient. There was no history of cough, hemoptysis, close contact with the TB patient. There are no history of jaundice, no history of passing dark color stools. There are no history of constipation or bleeding PR. Past history: patient gives significant past history of undergoing one operation almost 25 years back for the stomach ulcer, which the details which he remembers I will mention. That patient was told that in that operation a part of stomach was cut and the remaining part of stomach was joined to the intestine, and he remembers only some part of the event. This He was admitted in ICU and he received the blood transfusions, and he doesn't remember any significant post-operative complications for which he again would have to visit hospital recurrently or get admitted again. In personal history, patient significant personal history is patient used to smoke 5 to 6 cigarettes per day since last 20 years. So it comes around 5 pack years. Uh, Before the starting of the complaints, patient used to consume mixed diet, which, as I described earlier, gradually decrease and reduced over the 3 months, where he can barely take 1 or 2 idlis right now. And another striking personal history was bowel habits were reduced currently to one bowel habit per 2 days with normal bladder habits. In family history, there was no significant family history for the gastrointestinal or other malignancy or any abdominal surgery in the family. In the social history, patient belongs to upper middle class according to a modified Kupuswamy socioeconomic scoring system, and according to e-commerce scale, he is grade 1. So can I proceed with the summary, sir?
Yeah, I think so. But shall we the other two discussants? Whether, yeah, why don't you summarize and then we will proceed. Yeah.
So
Summarize.
we got one 74-year-old chronic smoker or status post abdominal surgery for gastric ulcer, now presented with early satiety, loss of weight, repeated vomiting, loss of appetite, and abdominal lump and abdominal pain. Uh, since all the features summing up since last recent 3 months, so probable differential diagnosis I would like to keep for now will be carcinoma stomach and pseudocyst of pancreas.
Okay. Now let me ask the other two discussants. Are you happy with the history? Is it complete? Would you like any additional information? Who wants to speak first? In the order in which your names are put there. Yeah.
Sir, regarding vomiting, sir, sir, I'm Dr. Sadgun Rao, sir.
Yep.
Sir, regarding vomiting, I want a detailed history, whether it is like a gastric outlet obstruction or is it only kind of thing, whether there is any stale food in the vomitus kind of thing. And second, and regarding the pain, he described it as epigastric region. So, is there any right upper quadrant pain, or is there any other risk factors for a chronic liver disease? Or because epigastric mass with loss of weight, appetite, and vomitings. So I just wanted to know any chronic liver disease risk factors are there in the previous things. And also he underwent a surgery at that point of time. Any blood transfusions were given at that point of time? These things I just wanted to know, sir.
Yeah, blood transfusion was mentioned, but Sadgun, I think I get your name right. Why
Yes,
are
sir.
you thinking of chronic liver disease at all at this stage? I mean, why are you transfusions were mentioned?
Yes,
Why are you
so
concerned about
I want to put the differentials like a mass lesion which is occupying the fundus, or some lesion which is causing less distensibility in the stomach like linitis plastica. So if at all mass lesion in the fundus, it can be primarily a stomach growth, which is adenocarcinoma or GIST. But GIST presentation is not like this. So adenocarcinoma I would like to consider, sir. Along with that, any left lobe HCC, which is causing an fundal compression, which is causing this loss of appetite, fatigue, and weight loss, and also vomiting. Epigastric mass lesion.
No, I personally feel it's a little far-fetched. Patient with vomiting as the dominant feature. And I think there was a mention about food which was taken just before. Yes, we could have done with a little more description of whether there was old food which came out, etc., etc., etc. But then I agree with you on that point, but I think that has generally been covered. Now, does Pawan want to add anything here quickly?
To answer for Sadguna's query,
Yeah.
actually, this patient had vomiting after few minutes of the ingestion of the food, which contained the fresh food, not the stale food, and he didn't have any distension prior to the vomiting. Like gastric outlet obstruction, patient would have like 1 to 2 days of gastric content accumulated. Then he will vomit out all of the sudden with regression of the gastric swelling which he perceives. So that is not present here, as I mentioned earlier. So that differentiates our case from the gastric outlet obstruction as queried by Dr. Sadhguna Rao. And yeah, blood transfusion history was there, but
yeah, the other candidate has any quick comments on the history? Any additional points you would like? The other discussant.
Is there any history of overt GI bleeding? I just wanted to know. Overt GI bleeding.
no. There was no passing of dark color stool. There was vomiting was not associated with the hematemesis, and no blood stained vomitus, as I mentioned earlier.
Okay.
History of
Now,
dyspeptic.
yeah, go ahead. History of
Dyspeptic symptoms the patient was having.
No such chronic dyspeptic symptoms patient had.
No, see, you must be clear. He has symptoms which to first look like a gastroduodenal disease. And now what dyspepsia do you want over and above all the symptoms that have been described? Now, okay, if you're talking about a past history of dyspepsia, well, that's one point that I would have liked. What were the symptoms when he underwent the surgery? It may not make a lot of difference to my approach to this patient, but I would have liked to hear the quick comment. Pawan.
Sir, actually the patient, I tried to dig out the history about his past history, but unfortunately he does not remember the much details.
Oh, fair.
What he remembers was he was admitted with abdominal pain. Yeah.
So let us move on. Now you gave us two differentials. Am I right?
Yes,
Why gastroduodenal? Why gastroduodenal? I mean, carcinoma stomach as your first possibility, and why you put pancreatic pseudocyst as a second?
First, because patient symptoms are like progressive over last 3 months. He had no history of any acute abdominal pain for which required admission or IV medications, or any rice tube was put to rule out the history of acute pancreatitis. And as his symptoms progressed over the past 3 months, with in the situation like loss of appetite appeared first, rather than any complications of the pseudocyst. loss of appetite, then loss of weight, then early satiety gradually appear. So it is indicating more towards the gastric carcinoma, which is hindering the distensibility of the stomach, rather than the
let me
extra
put it
abdominal
this
causes
way.
like the pseudocyst.
Let me put it this way.
Yes.
Can you
Yes, sir.
positively tell us these features tell me that it is gastroduodenal lesion more likely than pancreatic lesion? I'm specifically looking at the pain part. Did you get my question? Based on this
Yes, sir.
man's pain, could you justify?
This abdominal pain.
Hmm.
Yes, sir. His abdominal pain used to exacerbate with the intake of food, and used to even though pancreatic pain also gets sometimes exaggerated with the exacerbate with the abdominal food intake, but in our patient he gets somewhat relief with the pain after vomiting episode, that we see rarely in the pancreatic cause.
Yeah, unless a pseudocyst is situated in a key position where it can obstruct, it's unlikely that he will present with vomiting, and that kind of vomiting will have features of retention vomiting. So in addition to the pain, there are other features also, which so in fact, I'm not even sure why you brought in pancreatic pseudocyst at all. Well, maybe as a part of considering a differential diagnosis, but otherwise, it appears to me unlikely that pancreatic pseudocyst can of course present with vomiting, but please don't forget, this patient, according to your history, has a gastrojejunectomy. The intestine was attached to the stomach, right? So
Yes, sir.
I would like to include the previous condition, that is the previous surgery, and the recent onset of symptoms, pain suggestive of gastroduodenal pain, some kind of restriction to the intake of food. All of them would point to one most likely diagnosis, and that is a neoplasm in a post-operative stomach. Now, whether we consider other differentials, blah, 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 is secondary at this stage. Now, these are my comments. Well discussed. Any other comments from anybody else in the panel? Anybody?
Thank you, ma'am. You are there.
I am here, but I did not listen to the first part, so you just continue, okay? I'll
No,
follow.
can Pawan just summarize your history so that ma'am is able to get the
Yes.
gist of it.
Yes. Good evening, ma'am. Today our case is on 74-year-old male who is is a chronic smoker, status post gastric surgery almost 25 years back for gastric ulcer, as told by the patient. Now presented with loss of appetite, loss of weight since last 3 months, early satiety, repeated episodes of vomiting, pain since 2 months, and feeling lump in abdomen since last 1 month.
Any other information you have? 35 years back surgery? Any other information we have? Emergency? Was it planned? Was it associated?
Actually,
was it complicated, or what was it? Was it a bleed that caused the surgery, or was it a perf-like history that caused this, that resulted in the surgery? Any information we have?
ma'am, actually, I tried to dig out the surgery, but patient does not remember that past, unfortunately. But what he remembers was a blood transfusion was given. So I assume that can be peptic. Blood transfusion was given. He was admitted in ICU and transfusion was given.
So why did you
So that's
consider
what he remembers.
pancreatic pathology in this patient based on this history?
Because this early satiety, abdominal lump, pain.
The pain description, as Dr. Ganesh mentioned, the pain is something that you should be able to distinguish, as to what it is. There's outside noise, so excuse me for that. Yeah, the window. The thing is, the pain history is something that should be able to help you differentiate whether it is from the stomach or from pancreas. No? So why did you consider pancreatic pathology at all in this patient? Can you just expand within within a minute what was describe the pain? Can you just describe the pain?
The pain was
Just describe the characteristics of the pain which the patient
Just
had.
describe all the points for the pain.
ma'am, it was mostly epigastric, mild to moderate in intensity.
That's
It was not
interruption.
no
That channel,
radiation.
please switch off your video. Please switch off. All the people who are presenting only, please keep their video on. All others, except the faculty, please keep their video off and audio also off. Sorry for that interruption. Padam, Kadam, please continue.
So, ma'am, it's pain is mostly epigastric, mild to moderate in intensity with no radiation, and pain specifically used to exacerbate with intake of food. After a few minutes of the intake of food, which he tells he got some relief with the pain after vomiting episode. It is mostly it's dull aching, ma'am.
What I want to know is this particular pain. I don't think it fits in with a pancreatic. Dr. Ganesh, I don't know what was the discussion ahead, favoring more towards gastric pathology versus pancreatic. I don't know what was the discussion.
No. I mean, there is nothing much to suggest pancreatic pathology at all.
Exactly.
So why did it come into is it just because you want to consider? See, don't throw all your cards on the table at once.
Absolutely.
Only if you're pressed, do you want to consider anything else? You can even say, in my opinion, what other differential diagnosis would I like to consider in this patient? Well, can it be a mass arising from the pancreas, which is, see, this patient probably has two outlets for his stomach. One is the gastroduodenum, the pylorus and the duodenum itself, and the second is the GG. So almost everything seems to point to gastroduodenal disease. So I would be happy with that. I won't throw all my cards on the table up front. I would even, if I were asked, I would say it is not typical, but I can consider something pressing on the stomach from outside. Like, now what am I doing? I'm just pussyfooting around the possibility, trying to look at the examiner's face, or something in the gastric wall. These things did come up briefly in your, but then that is the way it should be. I feel that's about it.
Can it be hepatocellular carcinoma?
Yeah, somebody brought it up. Yes, let the candidate answer that. Presenter answer.
Hepatocellular carcinoma, less likely, ma'am. If the such presentation should have been with hepatocellular carcinoma.
I'll just tell you one thing, when we say hepatocellular carcinoma, then you just say patients with hepatocellular carcinoma would present like this, rather than saying less likely, unlikely. We're giving you a suggestion. Can it be hepatocellular carcinoma? Then you say patient with hepatocellular carcinoma can also present with abdominal pain, can also present with pain in the epigastric region. Most of the time, it will be a continuous pain. However, this particular pain will not be related to food intake. Mass can be felt and can be palpable by the patient. However, the pain characteristic will not be related to the food intake. See, anything can happen after the investigation, but when we're giving a suggestion, these are the things that you'll have to consider. You cannot exclude based on the pain, presentation, based on the characteristics of the pain that you presented. It can still be a hepatocellular carcinoma or mets in the liver that's presenting actually as a mass, and patient has got symptoms of stomach like early satiety, fullness, or whatever it is. Okay, so just keep that possibility. We can just move on.
May I just ask a few doubts?
Yep, go ahead.
So, Dr. Pawan, this patient, you said about the surgery, and you also said that a part of the stomach was removed.
Yeah.
Okay, so what do you presume, what do you think that surgery could have been?
It could be antrectomy with gastrojejunostomy, sir, done for the
Antrectomy,
gastric
okay.
ulcer.
Okay, so
For the
one
gastric ulcer,
possibility is
maybe
that it is
complication.
antrectomy. So what are the situations where people do antrectomy? And it looked obviously like an elective surgery or emergency surgery. Mostly it would be an elective surgery. So when you discuss the history of a surgery, especially abdominal surgery, try to say whether it was elective or emergency. Okay, because the diagnoses are likely different, the type of surgery are likely to differ. You are lucky here that the patient has told you that a part of the stomach was removed. What is the situation where a part of the stomach is removed? What is the situation where you have that problem? Where the surgeon removes a part of the stomach? Some audio disturbance is there.
In bleeding peptic ulcer, sir, in a CS stomach.
CS stomach, usually they do total gastrectomy or a partial gastrectomy radical. Okay, so remove part of the stomach. Is there any other situation? Yes. So do you think that your patient had this CS stomach so many years ago? How many years? 24. When was the surgery?
25 years ago, sir.
25 years. So do you think he had CS stomach at that time and he had a gastric resection at that time?
I think it's more likely because of peptic ulcers than gastric carcinoma. Because
okay, peptic ulcer. So can you specify it? Can it be duodenal ulcer or gastric ulcer? Is it possible? For what symptom was this surgery done at that time? Was it done for pain? Was it done for vomiting? Was it done for GA bleed? Was like that? So was it a protracted ulcer disease or was it?
Patient remembers abdominal pain only, sir, but
okay,
it can be bleeding peptic
because
ulcer.
why I ask these details are some of the examiners may ask you such details. Because in this case, you are lucky that he told you part of the stomach was removed. Sometimes we may not be lucky. They say, and we may have a midline scar or a left paramedian scar, and the examiner will ask you, can you guess what type of surgery was done on him, depending upon the symptoms subsequently. So can you guess on what type of surgery on stomach is done on the subsequent symptomatology? For example, if he had a GJ vagotomy, can he have some sort of symptomatology afterwards? Like that, no? That's depending upon the type of the scar, whether it is a paramedian scar or midline scar, whether it's a high scar. If there's a vagotomy, usually the incision will reach up to the xiphoid. Okay, so such clues are there. Okay, so you must utilize all those clues because in a post-op stomach case, the questions can be in any direction, but in this particular case, we have a focus on the mass and pain and vomiting. But sometimes if it is some other problem, the questions can be in any other direction and you must be ready with the answers for a post-op stomach related problem. Over to Professor Ganesh Pai. Sorry for that intervention.
No, good points all around. So if there are no additional doubts or clarifications, let's move on.
Yes, sir.
Pawan.
So, yes, sir. Sir, can I move on to general examination? So, a patient is conscious, oriented to time, place, and person. Is moderately built and.
Doctor, 1 minute. Summarize and give your differentials, syndromic diagnosis. Give your complete diagnosis now and syndromic diagnosis before we go to the examination. At the end of the history, summarize. You already summarized it for me. Now give your syndromic diagnosis and your differentials at this stage.
Ma'am, syndromic diagnosis will be the malignancy arising from the stomach, probably adenocarcinoma stomach, maybe laminitis plastica, considering the symptoms of
That's
the
too
patient
much of a
early
thinking process. What is your syndromic diagnosis in the syndrome? What is your syndromic overall? Abdominal pain, no? It's an epigastric pain. That's your broad, this thing with a lump, that's your basic syndromic. What are the possible etiology? One, you said CA stomach, post-op. Number two, you said is cirrhosis pancreas. Then we consider hepatocellular carcinoma. What are the complications? What are the complications this patient has? And status post-op stomach. Okay, there's a status post-op. We do not, maybe the stomach, maybe there was ileal perforation. We do not know. You've not yet come to this card. What are the complications the patient has now? Any complications like GI bleed or anemia or weight loss or jaundice or anything?
He has weight loss, anemia.
No, why is he vomiting?
Because of
See, the
poor
syndromic
distension of the
diagnosis
stomach
has
and
5
nausea.
components, no? Syndromic diagnosis, 5 components. First is a basic syndrome, and then you have the etiology, then you have the complications, then you have the comorbids, and the last is performance score. Now tell us just the complete before you go to the examination. Quickly. So we said abdominal pain. No, that is upper abdominal pain, basically. That's a basic this thing, along with a lump that leads to a definitely status post GJ. That's a comorbidity. That's a comorbidity. Etiology we've already discussed. Complications, as Sir said, vomiting, gastric outlet obstruction is possible. Gastroduodenal obstruction as a complication.
Pawan, do
there
you
Less
think
likely,
that
ma'am.
it is due to
Less
gastric outlet obstruction? Yes or no? If yes, what are
No,
your
ma'am.
points in favor?
No,
If
ma'am.
not, what are the points
no,
against?
no gastric outlet obstruction, right?
No gastric outlet obstruction, ma'am. Because
No.
patient has vomiting immediately after a few minutes of the having food, and which contained the food which ingested some time
Destroyed.
before,
Okay.
not like the stale food or abdominal distension like gastric outlet obstruction. Those symptoms are not here, ma'am.
So if a patient vomits within few minutes of taking food or seconds,
Yes,
when will such a thing happen?
if
When
nausea
will
is associated or
sorry?
within seconds, it will get in any gastroesophageal junction pathology, ma'am, or CA esophagus. But
we have not discussed anything about that. We have not discussed anything about that point. If a person vomits as the person takes food and the person vomits, is it bilious or non-bilious?
it should be
It should
non-bilious.
be. So what is it? What is in the patient?
Non-bilious, ma'am. It should be.
It should be, no, what was the patient? I do not know because I missed the initial part. Anyway, so that one complication is there, possibly gastric outlet obstruction. Any comorbidity?
No other known comorbidities, ma'am.
No comorbidity. Performance scale?
ECOG performance scale 1.
1. Okay. Now, so your differentials are those 3 that you mentioned. Okay. And without this, you should not proceed to the examination because your exams have to examination to confirm whatever your session. Now tell us the examination findings.
Sure, ma'am. Thank you. Ma'am, our patient is conscious oriented to time, place, and person. He is moderately built and poorly nourished. According to subjective global assessment score is 38, which shows severe malnourishment. Our patient is pale. He has no icterus, clubbing, cyanosis, or lymphadenopathy or edema. Pulse is 88 per minute, regular, good volume, no radioradial or radiofemoral delay. All peripheral pulses are felt well. Blood pressure is 120 by 70 millimeter of mercury in right arm supine position. Respiratory rate is 15 per minute, which is abdominothoracic. Temperature is normal. With weight is only 40 kg, height is 167 centimeters. BMI is 13.7 kilogram per meter square, which is underweight, ma'am.
Now, with that, your first description, when you said moderately built, so I thought one fellow was one real heavy built fellow, no, moderately built, and your BMI is now is 14.7. How are you accounting for these 2 statements?
Yeah, those please switch off video.
Poorly nourished, but moderately built, but the BMI is 14.7. Is it possible for any person who's not seen the case, and we're imagining a patient there with a 14.7?
Manwari, please switch off video.
Dr. Ganesh, please take this point.
Yeah, you have any comments to say?
Ma'am, though he was emaciated.
Just don't say poorly nourished and all. They will ask, how did you assess nourishment? Very in a simple form, just mention his BMI is 14.7. That's it. That's all. And mention about the frailty score and sarcopenia index. That's it. Just mention these two. Don't bring in all this poorly nourished but moderately built. And I was surprised to see that the BMI is 14.7. Be very simple, be very plain. Just mention what is there in the patient. You have to mention about the sarcopenia index and the French score. Mention just this and stop there. That's it. Does the patient have edema of the lower limbs? What about the cutaneous markers of internal malignancy? That's the most first thing that's what must come up. What are the cutaneous markers of internal malignancy that you look for in this patient?
Acanthosis nigricans.
Have you mentioned it?
Less
Have you mentioned it in your
receptor sign.
presentation? Are you coming with that presentation later? Or you missed on it?
No, I didn't mention about the cutaneous.
That is most important.
As they were not present.
Stomach, yeah.
Okay, go ahead, finish your physical examination findings, and if there is any clarification, we will intervene at that point of time. Please continue.
Okay, sir.
Professor Ganesh, you are online,
in systemic examination.
Yeah, I'm on. Continue.
Okay.
In systemic examination, I would like to examine gastrointestinal system first. So, oral cavity, gums look healthy. There are no dental caries or no evidence of any micronutrient deficiency. For the examination of the gastrointestinal system, I expose the patient from his nipples to the mid thigh, and in inspection, the findings for abdomen is scaphoid with visible round mass around 7 centimeters, which is visible in the epigastric region, which moves on respiration with normal underlying overlying skin. There is around 15 centimeter scar which is running in the midline from the episternum up to the umbilicus, and all quadrants move with the respiration well, and umbilicus is central and inverted. There are no visible peristalsis or pulsations, no dilated veins or sinuses. In the palpation, temperature looked normal. There was no tenderness. Vague round mass palpable in the epigastric region measures around 7 into 7 centimeters, which has the ill-defined borders with the nodular surface, and it's hard in the consistency, which is non-tender, non-pulsatile, and it moves with the respiration. The mass becomes less prominent on the rising test, and mass doesn't fall forward on the bending down. And liver, there is no hepatosplenomegaly. Liver and spleen were not palpable, and hernial orifices are intact. With percussion, liver span is 11 centimeters. Regional note was heard over the abdomen, except over the mass, which was dull on the percussion. Trop space was not obliterated. On auscultation, there was no significant findings. Pulse sounds are normal. There was no GRUI or venous hump heard. So, in rectal examination, on digital palpation, tone was normal. Rectum contained no fecal matter at the time of examination. Rectal wall mucosa was smooth, and there was no palpable mass. And other systemic examination, I found out normal. Can I move with the?
What are the positive findings?
Sir, positive findings was the mass around 7 to 7 centimeter is palpable in the epigastric, which is hard in consistency, nodular with irregular border, and the fingers can be insinuated above the mass, which this mass does not fall forward on the bending down and on.
Okay, all those things you told. All those things told. One is mass abdomen, which is seen in inspection as well as Pelton palpation. Okay, you said about movement with respiration. What is intrinsic mobility?
That mass is intrinsically is movable in all dimensions, sir.
So is it movable in this particular case? Because I couldn't read it.
It is movable, sir.
So it is moving in all directions. Usually we check in up and down and transverse. It's movable.
It's moving in all directions.
Most of the respiration, it moves in all other directions. Okay.
Yes, sir. Yes, sir.
Okay, over to Professor Ganesh Bhai, your comments.
The mobility, I'm a little confused you're trying to say it moves with respiration. You said it is not falling forward in the knee, elbow, knee, chest position. And you say its intrinsic mobility
Yes.
up and down and side to side is intact. There seems to be
Sorry,
a
sir,
little bit
that's
of
my mistake. Actually, it falls. Sorry, sir, that is my mistake. Actually, it was falling down on the knee and elbow position. I think that must be some mistake from my side, sir.
Yeah,
It
okay.
was falling down on the.
So there was an
Yes, sir.
inconsistency
Yes.
there, but let's
Sorry
move on.
for that, sir. Yes, sir.
Yeah,
Yes,
no,
sir.
that's fine. Yeah. So based on these characteristics, where do
Yes,
you
sir.
think the mass is arising from?
Sir, according after examination, it's confirmed that mass is intraperitoneal, and according to characteristics, mass probably arising from the stomach itself, sir. As fingers can be insinuated above, so mass from the liver is ruled out, or as mass is falling forward, so retroperitoneal like pancreatic mass is ruled out, and any abdominal mass, abdominal wall growth is also ruled out, as it does not become prominent on the Carnet test.
Is there anything relevant on umbilicus? Is that relevant?
Yes, sir.
That's a good point. Yes.
Sorry, sir, I could not get you.
Umbilicus, examination of the umbilicus was a question.
It is relevant or just passing mention is needed?
Umbilicus is inverted and in central, sir.
Is it relevant in such a case? To
In
look for
yeah,
something else?
sister, maybe deposits around the umbilicus can occur in the stomach. Sister Mary Joseph nodules.
The umbilicus, yeah. Perhaps if you say negative for that, you will get an extra point. Okay, because it is expected of you to say that it's absent. Please continue. I think he clarified on that, but in situations where there is doubt about your physical examination findings, the examiners may ask you to go and then re-examine and come back and report. And for heaven's sake, please go and examine the patient always. Okay, never ever say I am so convinced about my findings. Many students make a mistake. They refuse to go and examine, or they make a superficial examination in front of the examiners, and then have little extra problems. So if you are given an opportunity to go and examine the patient again, gracefully accept it, examine properly, come back and report. And if you have made a mistake, be very genuine and say, sorry, I made. In fact, examiners will appreciate that. Examiners will appreciate your frankness. Okay. Please continue. I think we can call in the next person. So after the physical examination, do you want to pinpoint a diagnosis, or you want to keep your wide differential diagnosis?
No, I would now pinpoint diagnosis to the CS stomach, sir.
Can you put it more specifically? Yes,
It's probably the malignant is probably the gastric malignancy in the form of linitis plastica, by considering the clinical features of the patient and examination findings that we have found.
Did you find any evidence of disseminated malignancy?
No, sir.
So that could be something that can be brought in at this stage, without evidence of dissemination. But then why do you want to bring in linitis plastica?
Just because the patient's symptoms are more considerable, like patient is having early satiety. It's to the extent that even a glass of water he cannot tolerate, and he vomits out. And
see, the problem is
showing this gastric distension, it is significantly distributed.
Remember, this is not a normal stomach. This, as
Exactly.
per your history, the volume of the stomach is already compromised by the previous surgery.
Yes.
Yes, sir.
Understand? So you can't expect it to be like a hugely voluminous stomach and expect a classic gastric appetite obstruction.
Yes.
There is
In
some problem.
fact,
You are telling linitis plastica and then you are feeling 7 centimeter mass. Does it go together?
exactly. Exactly. So linitis plastica may be a bit of an overkill here because 25 years ago, a part of his stomach was removed. When this new thing developed recently, he already has compromised space there, very limited space there. Even small things in that remnant stomach
Yes.
could behave as if, there is very little
Yes, sir.
space
Yes.
there. Yeah. And this is
Yes, sir.
especially true when you're talking about a 7 into 7 centimeter mass. So let us not go overboard. Yeah. Okay, good.
Yes.
So what do we do at this stage? I think
Dr. Ganesh, I think few things that in the examination, like exposing from the nipple to the mid-thigh and all, you cannot, I mean, all these things should not be mentioned and you cannot expose a patient to that extent. Okay. I mean, the way you described it, please see that you do not mention this. The other important thing is once you say it is round, then the margins cannot be vague. Okay. Once you say the mass is round with a dimension on either side, then you cannot have the mass as ill-defined. So either you say it's an ill-defined mass and then you don't use the word, when it is round, I mean, in the typical English, whatever I understand is round will have a definite margin. And don't say there was resonant sound was heard all over the abdomen. Doctor, these are all simple basic things, when I was just going, as you were presenting, these were the things that were crossing my mind. Would you look for a resonant sound all over the abdomen when you're percussing this patient? The other thing I would like to mention is at the DM level or DNB level, please do not go to the percussion and say the upper border of liver dullness is in the 5th space. You have to finish all that you want to tell about the liver in your palpation. We'll say the liver is not palpable, upper border liver dullness is in the 5th intercostal space, and it is moving well with respiration, whatever it is, you want to say, finish off everything. Don't finish off everything about the liver. And then in the percussion, you say the upper border liver dullness is in the 5th intercostal space. Okay, because we are waiting to understand, we are waiting to listen to all aspects of the stomach, all aspects of the liver and all aspects of the spleen. So it is in one, in fact, percussion today has limitation only for fluid or shifting dullness. Succussion splash is important in this patient. If you said the patient has got vomiting, I would be looking for that. Drop space, dullness, percussion is important. That's all. The few points that you were discussing, I've just put that in the chat box so that, and even for no one does knee elbow position nowadays. Examiners do not want you all to put the patient in that precarious position. Just ask the patient to move to the left lateral and see whether the mass just falls forward or it remains in that position. And you said moves with respiration. Which of these masses will move with respiration? Which of the masses in the epigastrium will move with respiration? It is only stomach, the stomach and the liver. That's it, no? So someone has asked in the chat box, can it be a transverse colon mass? So transverse colon comes a little further down. It's more towards umbilicus and no symptoms are there. So I've really not considered. So remember these few things, as we are writing and you're describing and you're saying, we'll say rounded, then it's ill-defined, then it is moving with respiration, then it's retroperitoneal. Then you're saying there's some percussion note all over, then you're putting knee elbow position. So be very careful, very careful in your presentation. In this particular patient, what we're looking forward to is your cutaneous markers of internal malignancy, Sister Mary Joseph nodule, and to describe the mass. And as Dr. Ganesh and Dr. Vijay said, you cannot use the word linitis plastica, which means that you know what's the diagnosis. Already the stomach portion, most of it is out, and here you're having a rounded mass. Okay, it may just be a nodal mass. That's it.
Yes.
Can it be just a nodal mass that you're saying? External genital examination, very important. This patient, you must say that the testis is normal, a male patient, no? Because I didn't get it.
Yes, yes.
Yeah, so all that is more
Yeah.
important. Finally, there may be a primary in the testis, and the mass that you're feeling may be secondaries, and it's a nodal mass.
Pawan, suppose it's a short case or a ward rounds in the examination, and you have got a central upper abdominal mass, upper abdominal center, midline mass, and what's the relevance of examining the testis?
Sir, it can be primary testicular mass with the lymph node enlargement.
Yeah, sometimes you may be given a case like that in the ward rounds, and then you have to complete the examination properly, like that. Now, Professor Ganesh Pai was asking you one question which was not answered properly. What are the evidence of, will you look specifically for the evidence of distant metastasis in this patient?
Yes, sir.
Like
I look
where
for
on?
the I look for the left supraclavicular,
Okay.
left axillary, left supraclavicular, like what was not left left
Okay, most
left
common left
axillary, like Irish
supraclavicular,
nodes,
and the other
then
one
plummer
you
shell,
already told rectal examination. In fact,
Irish
you
rectal
described in
examination,
great
plummer shell.
detail
Yes.
about rectal examination. What would I expect? Because there were the patient was not having any rectal symptoms or any bleeding to everything. So this rectal examination was mainly to look for any deposits. Okay.
Deposits. Yes, sir.
You went to great length about the mucosa and other things. So we were probably interested only in that deposit part. Was the examination of the spine relevant, spine tenderness, etc.? Eliciting spine tenderness. That is another place where you get metastasis into the spine, no? So,
Yes, sir.
Sister Joseph nodule, supraclavicular nodule, node, then rectal deposits or pelvic deposits.
Irish nodes.
Spine, yeah, spine. Some examiner in situ one should also palpate the scalp to see whether there is any bone nodules or any defects or etc. etc. Professor Ganesh, I thought you were trying to elicit these things. Am I right?
Yeah, some of those. Yes.
Yeah. Please elaborate if you have more points, please, for the benefit of the student.
In fact, in long case, the other systems were very cursorily mentioned because pleural effusion. These are some of the things which might become important. See, it's a large mass sitting there. So we don't know how long this disease has been there. For all we know, some of the aspects of this patient tell me that the symptoms are only of 3 months, so probably the disease is not very old, not too advanced. Some of the other aspects, well, I can't really say because he probably has a GJ, so a large area will have to be compromised before there is obstruction, before he starts vomiting, etc., etc., etc. So it's difficult to say how long this disease has been there, but the mass tells me. So a cursory dismissal of other systems looked a little odd, and yeah, that's about it. Yeah.
Mass was firm or hard?
Hard, he mentioned.
Yeah. Harder. Mass was harder.
Yeah, he said it is
Yes,
hard. Okay, can we proceed? I think he has finished the physical examination and he has pinpointed to carcinoma of the stomach. I think we can call in the next person to discuss how he investigate further.
What's the diagnosis? What's the final diagnosis?
Final diagnosis, ma'am, carcinoma stomach. In the
you complete it. Ma'am told you to tell so many things in your syndromic diagnosis. No?
Yes,
So,
ma'am. Patient presented with abdominal pain and lump.
No, nothing here.
Has
just a physical examination. Tell us the diagnosis, status, ECOG status, all those stuff.
The differentials, if any.
status post gastrojejunostomy patient, status post gastric surgery patient presenting with uh, abdominal pain, lump with physical examination. We found out the a definite mass in the epigastric
Doctor,
region.
we are just telling you to give you a final diagnosis, doctor. Don't please discuss again about the patient. What will be, after you write the case sheet in the ward, what is your diagnosis at the end of your history taking an examination? You'll be doing this in day-to-day, in your day-to-day practice in the wards as you are being trained during your training period. So what is your diagnosis what is your diagnosis or differentials at this stage? That's all that we want to know. Only then you can proceed with the investigations, no?
Epigastric
I think
mass probably of
Ganesh, I think these are this is where the candidates falter, so just help them out to know this particular, like they have to give us a diagnosis or differentials, and that's when the whole problem starts. Give us your diagnosis or differentials so that we know how we have to proceed with the investigation.
Yeah, Pawan, very simple. Let's all take a deep breath. You presented well. Now, you discussed well. Yes, we pointed out some small things here and there. Now, let's all take a deep breath. What you're being asked is, at the end of history and physical examination, after all the discussion, what is your diagnosis? Now, don't bring in abdominal pain. That's not a diagnosis. Okay? Don't bring in vomiting. Yeah. Answer.
epigastric mass probably of gastric origin and probably malignant growth of stomach, sir. Gastric malignancy.
Doctor, you can just say carcinoma stomach, number 1, post GJ status or post gastric surgery, number 1. Number 2, it could even be a lymphoma. Okay. It can be a GIST tumor. It can be a GIST tumor. So what I want you to convey is give us some differentials for your patient that you have. So the possibilities are CA stomach post GJ, but all I know, maybe there was a small growth there and it's a GIST tumor that has recurred. So it could be a GIST. Can it be a lymphoma? If it is lymphoma, what type of lymphoma are we dealing with? So these are the things that we're looking forward to when you give your differentials. Okay, with features of with gastric outlet obstruction or no gastric outlet obstruction. Give us a complete diagnosis so that when we go for the investigation, we tailor the investigations towards your diagnosis. That's all that we're expecting.
Okay.
See, if I'm asked, I would put it simply as gastric neoplasm in the setting of previous surgery on the stomach. I can even say possible resective surgery on the stomach. Resection has to have an anastomosis. Gastric neoplasm, I'm being a little non-specific here. Previous surgery, we know from the history that there was a resection and anastomosis is understood. You can add that, but then we don't know what anastomosis that is. Usually it is a gastrojejunostomy, blah, blah, blah. And then in the setting of neoplasm, is it a gastric cancer, gastric adenocarcinoma, one of the most common tumors? Is it something less common, like in the other two that we mentioned, gastric lymphoma or GIST? Now, I have sort of expanded it for your ease, but this is how, at the end of this, I would present it in probably the most simple way. Do you agree?
Yes, sir.
Yeah. Any comments from the other two discussants?
Yeah, other two discussants. We'll invite them.
Yeah.
No, sir. No, sir. Sir, no, sir.
No, sir.
Sadguna,
No, sir.
that means you don't have anything else to offer. Is that the meaning of no?
Yes, sir. I don't have anything other than these two offers.
Okay. So can we ask them to how to investigate this case?
Yeah, I think we should.
Yeah. So please let us know how you investigate. Who is going to tell us that? Okay.
Basic investigation, sir. Sir, basic investigations, complete blood count, liver function tests, and RFT and serum electrolytes will do, sir. In complete blood count, we'll look for anemia, sir, if there is anemia. Liver function test, liver function test, sir, to look for if there is a metastatic deposits in liver causing deranged liver function.
How do you find out that?
Sir, usually if there is a lymph node near the hilum, if the lymph node gets enlarged and it compressed, it can cause CBD obstruction and they can present with obstructive jaundice.
Sumukh, stop for a moment and take a deep breath. See, you are on the right track, but you are talking something else.
Yes.
You started with liver function test.
Yes.
Now, is it to look for obstruction from a lymph node? Is that what is expected in this patient?
No, sir.
Biliary. Then what is it that you are looking for? And I will put it this way. Tell me if I'm right or if you agree or don't. I would look for an abnormal LFT to see if there is evidence for secondaries.
Yes, sir.
At this stage.
Yes, sir. For liver deposits. Yes, sir.
Okay. What
Yes,
kind of abnormalities can you expect in the LFT? That's the obvious next question. In liver deposits,
they can present with hepatocellular jaundice, sir.
Come on, please. You must have seen enough number of secondaries in the liver. Is jaundice common in secondaries in the liver? Who is the other person? Can you answer me?
Sadguna.
Sadguna. Sorry, I'm not too good with names.
No, so jaundice is not common in early presentations, unless large mass forming lesion is present. I would like to see for liver enzyme
What's the most common abnormality on LFT in secondaries in the liver, secondary deposits in the liver?
Don't prompt in the chat box,
raised
please.
alkaline phosphatase. Raised alkaline phosphatase. Probably I would like to see, sir.
It is minor LFT abnormalities, typically raised alkaline phosphatase. Jaundice is a late feature. It is an uncommon feature. It is a feature of advanced disease. Okay.
Yes, sir.
And secondaries in the liver causing alkaline phosphatase elevation is much more common than lymph nodes sitting there or something. Secondaries outside the liver causing an obstruction, causing obstructive jaundice. So this alkaline phosphatase is not because of obstruction, but because of replacement of liver tissue with neoplastic tissue. In most of the people with secondaries in the liver, when the alkaline phosphatase is elevated, you will not find a biliary dilatation on imaging. Okay?
Yes.
Yeah. So that is why we do the liver function test. I would like to look at plasma glucose level. I want to know whether there is a diabetes which has been missed or which has gone undetected. Every patient we would look for a background renal dysfunction, a background diabetes. I would do that. In the LFT, this man is poorly nourished. I would look for an serum albumin also because I expect it to be low. Okay. So yes, till now, we have looked at these background laboratory parameters. We have also explained why, for what it is that we are looking for, why we are looking for. Now, so what investigation would you like to do next?
Okay, ultrasound abdomen to look for again liver metastasis. Chest X-ray to look for if there is any lung metastasis, and then after this we'll proceed with upper GI endoscopy. Basic investigation. After basic investigation, radiological first investigation, ultrasound abdomen to look for liver metastasis if present, then chest X-ray to look for lung metastasis. After this, we'll proceed for upper GI endoscopy.
Professor Ganesh?
Yeah.
Yeah, please.
Oh, sorry. Yeah, that looks a very reasonable approach. So do we have a chest X-ray? Shall we, one by one, who's going to tell us about the investigations that have already been, the reports available?
Yeah, I think Pavan, please show the investigation which you have, which are available, so that Sumukh can interpret.
Sir, I have biochemistry, histopathology, and the endoscopy.
Okay, whatever is available, please
Findings and
show.
CT findings I have, sir. Yeah, I will show, sir. Yeah.
Sir, he's having microcytic hypochromic anemia. Sir, hemoglobin is 9.3. He has a low MCV 67.7. MCH is also low, sir, 19.9. Serum iron is also low, sir, 50. And TIBC is around 440, sir. He's having microcytic hypochromic anemia, sir. Probably iron deficiency anemia with this, sir.
Why probably it is?
It is iron deficiency.
Look at the transferrin saturation. Yeah, go ahead. Next.
Sir, in the liver function test, total bilirubin is normal, sir. LF, SGOT and SGPT is also normal, sir. Serum alkaline phosphatase is mildly elevated, sir, 145. There is hypoproteinemia and hypoalbuminemia, sir. Synthetic function is observed. INR is 1.21. Renal function is normal, sir. There is mild hyponatremia, sir. Sodium is 129.
Yeah, good. All on expected lines. You see, we had anticipated some of these and they are there. Yep, go ahead.
Next, sir. Shall I next slide?
One minute. Yeah, 1 minute. Just.
Yeah, all on expected lines. Next one.
Yeah. Shall I go for OZD-scopy or CT?
Endoscopy. Endoscopy.
Which one is your choice? Pavan.
Yeah.
What you do in the ward, you follow that pattern.
Yes, sir. We went for OZD-scopy next.
Yep, go ahead.
Sir, in the esophagus, there is a mucosal break, sir. Then anasmotic site appears stenotic. Scope could not be negotiated beyond. Large areas of unhealthy mucosa seen along the greater curvature. Feels hard on biopsy. Poor stomach distensibility. Next.
Are you happy with that endoscopy report? Do you require more information?
Good question.
Yes, sir. In the endoscopy, usually if there is a mass, we have to look the site and location and the extent from G junction up to the tumor. Where is the tumor, sir? So the distance.
We have some more endoscopy report is there. Just show the next. No, okay. No. Go back. Okay.
Do we have any more information on the endoscopy, or do we at least have pictures?
No, we don't have, I think.
We don't.
Pavan,
Okay,
can you give us more information regarding what type of anastomosis it is?
So the positive.
What anastomosis is it? I hope it has to be GJ. Therefore, we expect a GJ. So you have to got GJ anastomotic site. You have to describe all about the site, whether it is of sufficient size, whether it is patent, the margins are okay, whether the margins are ulcerated, and usually there will be two stoma, afferent and efferent. Both stoma are you have entered. All those things you have to mention. Okay, one thing. And if the anastomotic site is completely stenotic, then probably you won't be able to tell all these things. Second, what about, we are not sure whether it is a gastrojejunostomy or andrectomy. There was a history that it is andrectomy. So what you find on andrectomy also be different when compared to a classic gastrojejunostomy, where you will be finding the gastrojejunostomy stoma plus the antropyloric region, and very often you may be able to go negotiate into the duodenum through the pylorus. Sometimes it may be stenosed. In this case, if the growth is occupying the antrum also, you will have a problem. You won't be able to go beyond. Okay, so this is a little problematic case wherein the anastomotic site is stenotic, and any part of, even then probably if there's some distal stomach there, you may be able to see it. But from this, we have no idea as to what type of surgery seems to have been done. It looks as though there is a GJ, and it looks as though there is unhealthy mucosa in the stomach and poor stomach distensibility. Only that much information is there. But when you describe, I think a lot of things have to be described.
Do we have information on the fundus and body of the stomach and the pylorus?
Fundus appeared normal, ma'am, and this body had this feature like unhealthy mucosa was seen on the greater curvature. That was the positive finding, along with
Is there a pylorus or there's no pylorus?
there is no.
There was no obvious growth or anything. There was no luminal narrowing. So if at all there is a pylorus or antropyloric region, it should have been seen. Okay, you are telling only some unhealthy mucosa. So if antropyloric region is there, preserved, you must be able to see that. So you are not seeing it, no?
Yes, sir.
Okay, so that means it is an andrectomy.
Andrectomy, yes, sir.
Okay, so your status.
Pawan, let me ask you this question. Would you like any additional information on this endoscopy? We've been discussing the same thing from different perspectives, but I'm asking you. Dr. Varghese Thomas said this is an incomplete report. He would have liked to see an additional. Would you like to see additional information? If so, what additional? Either of the other two discussants want to answer that question? Sadguna?
Sir, like previously said, I just wanted to know like fundus, body, and whether pylorus is present or not, whether it was gastrojejunostomy or Billroth 2, which was done previously. And also they mentioned unhealthy mucosa seen along the greater curvature. So there is nothing like we felt mass, whether that is separate from this or is it arising from this thing. And also I just wanted to know whether any extrinsic impression was found on the stomach with such a huge mass of 7 into 7 centimeters at any place like fundus or body.
Absolutely. There seems to be a lot of disconnect between the physical findings and the endoscopic findings. I will point out 3 points. One, the type, Dr. Varghese Thomas has already mentioned this, the type of surgery is not clear from this. We know there is an anastomosis. Poor distensibility, due to what? Is there a mass inside? Is it an infiltrative disease? Not that it is going to make a huge bunch of difference, but then again, this is what I would like to see in an endoscopy. There is a 7 into 7 centimeter mass on physical examination, and there is absolutely nothing to corroborate that in this endoscopy report. And unhealthy mucosa is a vague term, very, very vague term. So, because all of us are gastroenterologists, the lesson I would take from this is we have to be very clear what it is that we are looking for, how we describe it, so that the right message goes across. So 3 important points in this patient. The details about the surgery, it may not be possible because there is a lot of growth there, obstructing or limiting the passage of your scope, which is fine. Do mention that. Poor distensibility. Poor distensibility can be due to multiple things. In a case like this, it is either because there is mass all around, circumferential mass, or there is evidence of infiltration as in a linitis plastica, you may not see a typical growth, but you may see that the stomach is not distending and the mucosa is not pliable. You will get it at the time of biopsying. It is thickened. So poor distensibility because of thickened mucosa. That's how you see it in diffuse infiltration. The term linitis plastica came up sometime. In fact, the folds may be gone and the stomach may not be distant. The mucosa appears thickened and not distant. So some of these things I would have liked to see in this report, which would have corroborated with the 7 into 7 centimeter mass. And I agree with Dr. Varghese comments. We need additional information on this endoscopy. Anyway, pictures not available. So what do we do at this stage?
Radiological investigations.
Yep.
You're an endoscopy, so what next?
So what radiology? Yeah.
CT abdomen, contrast CT abdomen we would do.
Yeah.
What was the biopsy report?
But
This was the biopsy report.
So based on this report, what will be your next investigation?
The CT contrast CT abdomen, to look for the
Is CT abdomen enough for you? Would you like to look at the CT of other parts?
yes, sir. CT to look
Abdomen
for
and pelvis with thorax.
yes, sir.
Would you agree?
Yes, sir.
Yeah, go ahead. Let's CT abdomen is important, no doubt about it. Let's look at it. Yeah. Now,
Can we show the picture?
yeah, is somebody interpreting the CT for us? Interesting.
Sumuk, can you?
Yeah, Sumuk.
So he won't be able to point out.
That's okay. Tell us left side, anterior, right side, posterior, whatever, in front of, behind. What do you see in this?
Sagni, can you give the rights to use the pointer to Dr. Sumuk?
Sir.
Okay, Sumuk may be able to use it.
Sumuk, start at the left side of that picture, your left, and keep moving to the right and tell us what you are seeing there on this one single CT slice.
Can you use your pointer? Let us see whether we can see it.
Sir, no, sir. I am unable to.
Go ahead. Go ahead. Doesn't matter. You can tell us what you see, left or right.
Pawan, you will be able to use that. Okay, Pawan?
Sir. Yes, sir. Yes, sir.
You show each area and then he will say.
Sir, there is.
Now one pointer is moving. That is Pawan's.
Yes, sir.
Yeah, that is my point, sir.
That shows some thickening, sir. There is a there's a long segment thickening there, sir.
Thickening of what?
Stomach, sir. Long segment.
There is a thickening of the stomach wall.
Wall.
Is it localized? Is it diffuse? Is it confined to some parts? What do you think?
It is diffuse, sir. It is diffuse.
Fairly diffuse thickening of the part of the stomach that is seen in this section. Do you agree?
Yes, sir.
Do you see anything else in the stomach? Do you want to say anything else about the stomach?
Hmm. No, sir. No, sir.
I see something bright. I see something dark in the center, and around that, especially towards the right side, I see something bright. Any comments on that?
No, sir.
Okay.
I
Any
don't know.
other? See, do you normally see mucosa enhancing like this?
No, sir.
There appears to be a fairly thick layer of enhancement. Now, what exactly this means, I cannot say at this point. Anybody else knows better can enlighten me on that. But in addition to the thickening, fairly diffuse thickening of the gastric wall that is seen in this section, I also see a layer of enhancement.
Okay, I will just ask the host, Mr. Sagnik, can you give the rights to use the pointer to Professor Ganesh Pai? Are you there?
Yeah, it's okay. It is the innermost layer outside the air in the stomach. I guess I have made it clear. Yeah, exactly. Yes. Now I don't know what exactly it means. I don't know if the others have any comments on that. But then let's move on. Do you make any? Do you have any other findings in this particular cut? Who's going to answer that?
No, sir.
No other findings?
From the right side of right wall of the, that is along the lesser curvature, I think that mass lesion I could see, sir, because below that the pancreas is visible, which appears to be normal, and this mass lesion is present.
Is the pancreas normal?
I think pancreas
Phillips?
appears.
To the left of the pancreas, what do you see?
There is
To the left of the pancreas. Do you see the gallbladder? Any comments on that?
Gallbladder is distant.
It's distended. That's neither
Distended.
here nor there. Neither here nor there. Now move. Look at the fundus of the gallbladder. No, not the fundus. Look at the part of the gallbladder away from the fundus and move a little anteriorly. What do you see there? The same consistency as the gallbladder. Can you see the portal vein here in this section?
No.
yes, sir.
Can anybody who has a pointer, can you see the aorta?
Yes, sir.
Can you, what is taking off from the aorta? Taking off from the aorta? In front of the aorta, that one, yes.
Which artery?
Thank you.
Superior mesenteric artery.
Superior mesenteric artery.
Now move to the right of the patient. Our left, patient's right. Our left, patient's right.
That is
Yeah, what do you see there? What is that structure? I don't know. It's a little tricky to comment based on a single slice. Is that the bile duct?
That is CBD, which is
I don't
dilated.
know. I would stop here. I would
Looks
stop
like a
here.
CBD. Yeah, because there is no other outer structure seen in that area, no? So
It is close to the portal vein at its confluence, and it seems to be in the head of pancreas, and it seems to be very prominent. So a little bit of a surprising finding there for me. And the gallbladder is well distended, which I said was neither here nor there. But now I am seeing what I can't measure. This is a 70-year-old man, so we should make an allowance for his age also. So what does all this mean, and what does the CT report tell us? Or would you like to look for anything else from the CT in other cuts?
do we have other cuts pictures, Dr. Pawan? Do we have?
would like to see the liver metastasis and
Okay.
lymph nodes, perigastric lymph nodes, and also celiac and other celiac branches lymph nodes, whether they are enlarged or not, to stage the malignancy.
Yeah.
And any ascites if it is present, to look for the peritoneal involvements.
Yeah.
But
not just ascites, it may even be a plastic kind of involvement of either the mesentery or thickening of the peritoneum, especially the mesentery. Okay. Right. So that bile duct came as a little bit of a surprise, but then I would like to trace it down to its lower end. I would like to measure it. This is a 72-year-old gentleman. I will make an allowance for his age. So these are the additional findings that I would like to look for in the CT. Now, do we have any information on any of these things on the CT report?
Pawan seems to have logged out, maybe net failure. I will just, I have the findings, I will just go through it.
Yeah, yeah.
No, so I'm back, sir. I'm sorry for that.
Okay, fine. Just show us the
Yes,
CT findings.
Yes, sir. Yes, sir. Just a minute, sir.
Yeah, there are some more films, some more pictures.
There are some more cuts. Yes.
Next one, yeah. Next one, next picture.
Picture.
Yes,
CT picture. Yeah.
Yeah.
Now, any comments on this? Who was discussing the CT? Any additional comments? Any additional findings?
No, sir. No additional opinion.
Yeah, I can't see any additional findings. Yeah. So we'll go back to Pawan. You want to give us the findings?
Right.
Uh, There is-
Vamshi, please switch off.
CT shows the evidence of gastrojejunostomy. Sir. There is a long segment mass lesion involving the body and antrum of the stomach, approximately 9.5 centimeters, which involves the proximal aspect of the jejunostomy loop. Fat planes between the mass and pancreas and mass and undersurface of left lobe of liver is lost, possibly neoplastic linitis plastica. There are no para-aortic and no focal liver lesions. Sir.
Good. So this has some important information for me. I've not seen all the pictures, but a radiologist has reported body and antrum of the stomach, which means a resection was possibly not done. I'm a careful person. We all
Yeah,
can
I
make
think the
mistakes.
antrum is there, no? And they have said gastrojejunostomy. Yeah.
Look like. Okay, that is beside the point. So what additional information from the patient's illness point of view does the CT give you? Who wants to answer that? Do we go back to yeah. Okay.
There is adjacent organ involvement. That's what the fat plane lost. So there is involvement of the adjacent organ, pancreas as well as liver.
That is what the CT would suggest to us. So what are the implications of that?
This is T4 B disease, sir. So advanced malignancy.
Mummy. Amman kubra, amma.
Oh,
Amman kita
I think
Vamshi,
curative
please
options
switch off
are
your, please mute your audio. We are listening to what you're talking to your family. Please switch off. Vamshi, there are two login.
Okay, so what are the implications of this?
so curative options are limited for these patients, are not possible for these patients, I think, sir.
Would you say
chemotherapy and
limited?
palliation.
Not possible? Would you see? We have to be a little careful with our words. Yeah.
Not possible, sir.
Wow. Okay. So what next?
We will increase the speed because at 9:45 we may lose connection.
Yes, sir.
It
On
may be
biopsy,
extended to 10.
on biopsy, I would look for. Now I'm thinking of palliative chemotherapy, sir. First thing, so I would like to look for HEP2 positivity on the biopsy, and also microsatellite instability molecular markers on the biopsy, and to go for palliative chemotherapy. And second thing, regarding nutrition, part, sir, there was actually anastomotic stenosis through which even a gastroscope could not be passed there.
So
Yeah, yeah.
So I think
good you brought up the
endoscope.
nutrition issue, but how are you going to tackle them?
So endoscopically, I would like to try to manage the case by putting a self-expanding metal stent in this place, sir, because the entire stomach was involved with the malignancy. So surgical option, and the second thing would be percutaneous endoscopic jejunostomy, PEJ. These two options I am thinking at present, sir.
No. Percutaneous endoscopic jejunostomy.
No,
when you can't.
We are not able to go beyond. Sorry. So metal stenting across the anastomotic site. I'll think.
If that is feasible, depending upon the extent of involvement of the, that's probably the correct approach to this patient.
Yes.
So what do you expect? Let us say you put a metal stent, you have started feeding. You now, would you expect him to tolerate the kind of diet that you want to give him?
At
to
this
build
point
him up?
of time, no, sir. Actually, he is from 3 months. His food intake was decreased around more than 60 to 70% as far as he told, and also nutritionally deprived because of his albumin is low. We don't know other
That's all we
electrolytes.
know. The answer is simple. See, listen, the answer is simple. I don't expect, because the stomach almost, almost the entire stomach appears to be diffusely involved. So one may have to modify the diet intake. How do you modify it? Yeah, there is a question. Where do you put the stent? Who wants to answer that? Where do you put the stent?
I was thinking anastomotic site, sir.
Anastomotic site. What is there at the anastomotic site?
That was gastrojejunostomy. So at that point of time, he mentioned only a stenotic narrowing. So if at all we can.
See, the point is, at the you are looking at the gastrojejunostomy. Your scope is right in front of the gastrojejunostomy. Any gastrojejunostomy you do. How many openings are there in front of you?
Two openings are present.
Two. So the question becomes very relevant. Where do you put this?
Into the efferent, towards the efferent loop, I would like to put the.
How do you know?
By using the fluoroscopy, we can know by putting the contrast whether
fluoroscope is there in front of you. The patient is under the fluoroscope. The scope is in front of the GJ. The anastomosis is sort of involved by the tumor. Now, what do you do?
I'll try to pass.
Are these questions a little too advanced, Varghese, for this batch of students? I don't know.
Pardon?
Are these questions a little too advanced? For
No. Because in the examination they will ask, because the management part, no. Because if surgery is not possible, it is palliation, and they have to know. It's good that you are asking these questions.
Yeah, anybody wants to answer these questions?
Pavan,
Sir,
are you there?
Sir, yes, sir, I'm there, sir.
Is it such very simple to anastomose this GJ? Like
No,
what you do
no,
in a
it's
gastric
not.
outlet or in a
No, sir.
colon? It is anatomically a complex area.
Yes,
And
sir.
okay, so
Yeah, what I would do is I would pass a wire. I tried to pass a wire
Okay.
into the what I suspect is a efferent loop. I will pass a double lumen cannula over the wire. I will put some contrast beyond the obstruction. If the contrast is immediately draining away, then I know. It's not easy. What is away is a very relative thing here, but the direction of peristalsis. Now, if you put contrast into the afferent loop, the direction of peristalsis is towards the stomach, and you will probably get some regurgitation of the contrast that you have put. You can see it under the fluoro also. You can see it on endoscopy. Not easy, but then this is probably the only way to find out where to put the stent. Efferent loop, put some contrast, it will drain away into the jejunum. It won't reflex back into the stomach. And then you assess the length of the stricture, and you can hopefully, you will be able to put a expandable metal stent. As far as the diet is concerned, it depends on what the patient tolerates. A lot of the gastric mucosa is already infiltrated. He needs a lot of calories and proteins in addition to micronutrients. Micronutrients are fine, they are probably easy. He needs calories and proteins. It may have to be delivered in small, frequent meals, feeds, and maybe also to an extent as liquid diet. In other words, I will try test liquid feeds first, increase the caloric and protein intake fairly quickly, and try to make up with very frequent feeds. So this is how I would like to manage the patient's nutrition. Okay?
Yes.
Yeah. That will probably get him ready for his palliation, further palliative chemotherapy, if at all. Yeah. What about palliative chemotherapy?
Use
Yeah. Anybody answering that question?
Two-drug regimen is better than three-drug regimen, sir. So generally, a taxane plus platinum compound like paclitaxel plus paclitaxel plus carboplatin or oxaliplatin also can be given. So and the other thing is, according to NCCN thing, we can think of two things. If he is both VEGF and chemotherapy, if he can tolerate, then we can give ramucirumab plus paclitaxel. And if he is tolerant to only one thing, we can give only one drug, sir. And the other thing, if third line we wanted to go, then if he is fit for oral drug, then triflu. If the second line is not possible, then in third line, if he is fit for oral drugs, we can give trifluridine or tipiracil. If only IV preparation we need to give, we should give only irinotic and basic things. Sir.
Yeah, that's probably roughly about what I can say. So, any other issues? What about his age? How will he tolerate all this?
74 years, sir.
Mhm. Yeah. Any other questions, comments from anybody, any side?
End of life care.
Yeah.
Suppose technically you are not able to pass a stent.
Then
Then
by
how will you
taking
feed
high
him?
risk, then by taking high risk consent, we can go for feeding jejunostomy, sir.
Okay. I think it's 9:45. If there are no more questions, can we? Do you want to ask any further clarification, questions or comments? I think can you give us a take-home message, Professor Ganesh Pai, for the candidates regarding the case?
Yeah. Fairly well presented, but I would have liked to hear a little more about the abdominal pain and the way you came round to your differentials, your most likely diagnosis in a fairly good way, but these additional points about the vomiting and the pain would have helped there. Now
we are not able to see you properly.
Sorry.
It's dark.
I'm sorry, I get restless. I was walking up and down.
Okay.
I get restless sitting in a place. Okay. Yeah, the light is on my face.
Okay, now it's fine. Now it's fine. Okay.
Yeah. So, yeah, well discussed. Comments from others. Jayanti, I don't know if Jayanti is still on or.
Jayanti, are you there? No, I think
I'm
whenever I
listening.
pause, yeah, she's there.
I'm listening. Yeah.
Comments, Jayanti. Yeah.
Yeah, I think what most important is, I think the candidate who said that diagnosis of linitis plastica is a dangerous, comment, like that means you know what the diagnosis is. So always have a differential, especially with the masses. Your history should be, should have given us a clue that you're dealing only with the possibility of a mass arising from the stomach, give a differential of the various neoplastic lesions based on the age of presentation, and be very careful in few of these terminologies which are highlighted. That is, you say well-nourished, moderately built, and then you give a BMI of 14.7. Examiners, they actually, it's not that they want to fail the candidate, it's just that we want to know whether you have a direct approach to the patient in the natural sense. Suppose this patient comes to you in the outpatient clinic, I think you will really not, you'll not say he's well built and then also say that his BMI is 14.7. So be very simple in your terms that you're using. Always have a sarcopenia scoring and frailty index, which will tell us that yes, the patient is weak and marasmic. And a few other things, history, the examination findings, I've already mentioned that. And of course, the management bit, yes, each examiner will have their own whims and fancies, so be prepared and be aware of the various chemotherapeutic agents. And for CA stomach, they will ask for HER2 mutation. This is something that you need to know, because that the specific drugs that can be used, if it is HER2 positive, the outcome is much, much better. Yeah, and that's what I said. The vomiting, I think one of the candidates said the patient cannot have obstruction. It's that. The patient has vomiting. In a patient with a mass with a vomiting, patient has a complication of gastric outlet obstruction. Understand? So just be very careful in your presentation, because basically this is exactly what happens. We'll be noting down all the points as you describe, and then we'll start asking questions. So just be careful about that. Okay. Otherwise, presentation was good and good discussion too.
I do agree. It was fairly well discussed. The only thing I want to stress again is that if it is a post-op stomach case or any post-op case, the examiners may try to assess your knowledge about surgery by asking various questions, especially if it is stomach. And regarding post-GJ complications, in this case, initially we were given an impression that a part of the stomach was removed, and in the end, it turns out to be only a simple GJ. No, so sometimes they will ask you, can you guess the type of surgery done on the basis of post-op symptoms? So post-op, post-GJ symptomatology will have to be thorough. Nowadays, we don't see such patients because GJ is not done very practically not done nowadays at all. So you may not be seeing on a day-to-day basis, but at least for theoretical basis, theoretical sake, you please read all those things. I think it was a fairly good discussion, and Professor Ganesh Bhai, I want to thank you on behalf of all the students and on behalf of ISGK and on behalf of us, both of us, myself and Professor Jayanti. I want to thank you for joining us today, and we look forward to further such cooperation. Dr. Jerry, are you there for the formal thanks?
Yes, sir. Yes.
Okay, please.
On the behalf of residents, I will extend my sincere gratitude to Ganesh Bhai sir for joining us today as faculty. Also thank Verghese Thomas sir and Jayanti ma'am for moderating the session. I also thank the IST coordinators and the Clinic platform for organizing this meeting. Thank you.
So thank you all.
Thank you and good night.
Good night.
Good night, Ganesh. Good night.
Good night to all of you.
Everybody. Yeah. Sorry, again, I'm restless and running around. Yeah.